الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. Our lecture today is Sexually Transmitted Diseases, abbreviation STDs, by Professor Mahmoud Hani Sulaiman. Introduction. Sexually transmitted diseases are group of diseases transmitted by sexual contact caused by a wide range of pathogens and clinically mainly three different syndromes. Urethral discharge, vaginal discharge, genital ulcer. Discharge from urethra or vagina and genital ulcer. Continued introduction. Some are curable. Some of these diseases are curable, while others can only be controlled. Previously, sexually transmitted diseases were called venereal diseases, VDs. Adjective venereal derived from Venus, goddess of love. In view of social stigma attached to VD, WHO changed in 1974 nomenclature to sexually transmitted disease. Current terminology is sexually transmitted infection since 1999, as it incorporates asymptomatic infections also. Sexually transmitted infections constitute an important public health problem due to health, social, and economic results. It has health results, social results, and economic results. Health results occurs mainly among women and children as cervical cancer, pelvic inflammatory disease with resultant infertility, ectopic pregnancy, and congenital infections as syphilis, ophthalmia neonatorum, HIV, and hepatitis B, stillbirths, and prematurity. Social results is stigma and discrimination, falls mainly on women. Economic consequences equal loss of productive life years affecting progress and development of country. Moreover, presence of sexually transmitted infections can increase risk HIV 6 to 10 folds. All this leads to urgency to problem of sexually transmitted disease control. Extent of the problem of sexually transmitted disease. Globally, sexually transmitted infections are a global problem. True incidence of sexually transmitted infections is difficult to estimate due to underreporting and secrecy that surrounds them. Underreporting is due to the following reasons. First, disease is concealed by patient due to stigma and shame. Second, disease is often not diagnosed properly. Third, taking self and incomplete treatment by patients. They treat themselves. WHO estimates that at least 333 million new cases of sexually transmitted disease other than HIV occurred in 1997 globally. On average, per day, 900,000 people infected each day. About million, almost 1 million infected each day. 90% of them occur in developing countries. Major sexually transmitted disease: gonorrhea, more than 60 million per year, genital chlamydia infection more than 92 million per year, syphilis 12 million per year, chancroid 7 million per year, genital herpes 20 million per year, genital human papilloma infection 30 million per year. A big numbers globally. WHO reported worldwide 340 million new curable sexually transmitted infections per year. Large percent of them among females in reproductive age. Surveys in family planning and antenatal clinics in developing countries indicate prevalences of syphilis, gonorrhea, and chlamydial infections range between 6% and 40% of the attendees. In many countries, sexually transmitted infections among top 5 diseases for which both male and female seek care equal considerable drain on health services. Although infection rates nearly similar in both men and women, burden of serious consequences of sexually transmitted infections falls mostly on women and their infants. Sexually transmitted diseases in Egypt. An Egyptian study on sexually transmitted infection in a ST clinic showed that about 72% of patients had one or more sexually transmitted disease, while sexually transmitted infections not detected in about 30% of study population. Positive cases more prevalent in adolescents and young adults, about 60%. High prevalence of STD detected in males, 73.5%, than females, about 25, about quarter. In singles, about 65%, than married, about 31%, divorced, about 3%, widowed, about 1.5%. Rate of positive cases high among those with 5 sexual partners and in heterosexuals. All STD positive patients were not condom users. Most of patients were of low socio-economic class, more than 85%. Sexually transmitted disease were common among those with preparatory school education or illiterate than those with primary school level or university or institute. So the STD increase with illiteracy. Among positive cases in gonorrhea in about 37%, T. pallidum in about 31%, HBV and HIV in about 15%, and HCV in about 12%. This graph shows incidence per 1,000 of 4 curable sexually transmitted diseases in Eastern Mediterranean region, of which Egypt is part. It shows 4 diseases: chlamydia, gonorrhea, syphilis, and trichomoniasis. This graph shows evaluation of some STDs in various Egyptian groups in Cairo. In year 2000, FP equal family planning attendees. It was done in family planning attendees, ANC antenatal care customers, IUDs injection drug users, MESM men have sex with men, FSWs female sex workers, and diseases syphilis, gonorrhea, chlamydia, trichomoniasis. Factors affecting epidemiology of STDs. Agent factors. There are about 25 pathogens responsible for sexual transmission of various diseases from person to person. Most of them require 25 pathogens. Mostly require a break in epithelium to enter body, and such a trauma readily occurs during sexual contact, and so transmission from infected partner to healthy partner occurs. Disease agents and diseases caused by them are grouped as follows. The coming table. Bacteria, Neisseria gonorrhea, Chlamydia trachomatis, which cause lymphogranuloma venereum, Treponema pallidum, causing syphilis, Haemophilus ducreyi leads to chancroid, Mycoplasma hominis, Ureaplasma ureolyticum, Campylobacterium granulomatis, Campylobacter, Group B Streptococcus, bacterial vaginosis related organism, B viral agents, human alpha herpes virus 1 and 2, human beta herpes virus 5, hepatitis B virus, human papilloma virus leads to genital warts, molluscum contagiosum and HIV. Protozoal agents, Entamoeba histolytica, Giardia lamblia, Trichomonas vaginalis. Ectoparasite, Sarcoptes scabiei and Thyrus pubis. Fungal agents, Candida albicans. 25 pathogens. Host factors. Age, incidence of STI is highest in age of 20 to 30 years, then 15 to 19 years, and above 30. Sex incidence increase more among males than among females in developing countries. However, severity is more among females, but it is same in developed countries. Marital status, high among the diseases are high among single, divorced, and separated individuals than among married couples. Socioeconomic status, people of lower socioeconomic status are more affected. Occupation incidence is high among commercial sex workers. This graph shows bridging population. In order to transmit disease to general population, there is a bridge between the high-risk groups and the general population, which is the bridging population, composed of clients of prostitutes, partners of drug users, patients of STD, migrant population. Social factors. STI called social disease due to prevalence of social factors as follows: prostitution, poverty, illiteracy, polygamy, and polyandry. Prostitution acts as the reservoir of infection, called CSWs. Poverty, extreme poverty. Illiteracy, associated with emotional immaturity. Polygamy, one person having many wives, many sexual partners, still practiced in some places and predisposes for increased STI. Polyandry, one woman having many husbands, also responsible for increased STDs. Social factors continued: broken homes, sexual disharmony, social disruption, social stigma, co-education, and co-work. Broken homes in families with death, divorce of parents, children are likely to go astray in avenues of pleasure predisposing to STI. Sexual disharmony among married persons due to strange relation predisposes them to become victims of STI. Social disruption like famine, war, floods, and other disasters. Social stigma attached to STDs associated with shame will lead to non-detection of cases, not disclosing sources of contact, taking incomplete self-treatment will lead to increased prevalence of STIs. Co-education and co-work also foster casual sexual relationships. Demographic factors as industrialization, urbanization, migration of people to active areas seeking for work, eruptions of slums away from family also foster casual sexual relationships as among long-distance truck drivers occupation. International travel. In these days of jet travel, there is a rapid spread of STIs internationally. HIV and AIDS is current pandemic in world. Change in lifestyle. Alcoholism increases desire of sex and encourages prostitution, which in turn increase sale of alcohol. Present youths want relaxation of moral and cultural values. They want freedom from supervision. High-risk groups and occupational groups at risk. Those who spend long days away from home like seafarers, truck drivers, defense personnel, immigrants, refugees, labor class, tourists, professional travelers, commercial sex workers, homosexuals, hotel staff, convicts of law and order, call girls, etc. High-risk groups and occupation groups at risk. These high-risk groups are identified as core population groups from point of view of transmission prevention and control of STDs. Coming slide. All above mentioned socio-psychoeconomic factors are identified as risk factors or makers of STDs. This is the chain of transmission of HIV, human cases and carriers, direct contact with blood and semen, productive age group 20 to 50 years, homosexual receivers of frequent blood transfusion, marginalized population, intravenous drug abuse. This is the core group includes CSWs, commercial sex workers, homosexuals, call girls, drugs users, hotel staff, bridge population include client of CSWs, STI patients, refugees, migrants, partners of drug users. Prevention and control of STDs. Elimination of reservoir, breaking the channel of transmission, protection of susceptible. Elimination of reservoir. Elimination of reservoir is by case detection and complete treatment. To eliminate reservoir by case detection and complete treatment. Early case detection of supreme importance. More number of cases detected by following procedures. Screening or contact tracing. Screening mainly consists of high risk screening, selective screening of core population groups. All these high risk population examined clinically and also by lab due to they are apparently healthy individuals. Screening also for other groups as blood donors and antenatal mothers. Contact tracing, tracing sexual partners of diagnosed STI patients by rapid ways as telephone to identify them before completion of incubation period and asked to attend to STI clinic for exam and treatment to turn them non-infectious. This procedure is difficult but not impossible. The success depends upon gaining patient confidence. To be continued, cluster tracing, cluster testing. Here, diagnosed STI patient asked to give names, address, and other persons of either sex who move in same socio-sexual environment. Such persons are screened for STI. This procedure helps in detection of more number of cases as among homosexual and CSWs. Elimination of reservoir continued. Case holding and treatment. Giving treatment correctly and completely and confidentially. This is the mainstay of STI control. There is tendency among such patients to drop out before treatment is complete, so becoming repeaters. So follow-up of them is essential by outreach activities of STI clinic and is an important work of medical social worker of STI clinic. Administration of full therapeutic dose of treatment to contacts or to recently exposed persons even before getting results of investigation is referred to as contact treatment. Contact treatment. It is highly effective. Breaking the channel of transmission of STDI. Complete abstinence from sex is best way to prevent STIs. Protection of susceptibles. This is practice of safe sex. Having a faithful sexual partners, practicing monogamy, using condom if sexual partners is more than one, condom to be used correctly, continuously, and consistently. That is to say, one condom for every act of sexual intercourse. One condom for every act of sexual intercourse. Other measures: sex education, alter risky sexual behavior. At present, no vaccine is available except for hepatitis B. Establishment of STI clinics for early diagnosis, prompt treatment with lab, contact tracing, cluster testing, follow-up, especially urban areas, separate clinics for men and women. Implementation of legislative measures to abolish prostitution and encourage patients to seek early treatment and help in contact tracing and the cluster. Barriers for prevention and control of sexually transmitted diseases in Egypt. Barriers of STIs prevention and control in Egypt. Many patients, in response to stigmatization and sometimes criminalization, do not seek treatment. Difficulty accessing STIs clinics, few and in major urban cities. Weak reporting, insufficient surveillance system, refused to discuss these matters. In addition, discussion of sexual practice is culturally difficult throughout Egypt. Barrier methods of contraception, which offer some protection against STIs, receive little promotion and use. Challenges for STIs prevention and control. Egypt facing several challenges. Weak system existing for prevention and surveillance. Unexpected influx of refugees, inferior status of women, large immigration movement of men to earn living, continued low condom use, hidden commercial sex work, infection concealment, unclear pattern of IUDs. Ninth, paucity of trained investigators. This is the clinical control points for preventive and clinical interventions against STDs. As you see, there is a number whose behavior and ecologic settings result in exposure to STDs. This is a large number. Lesser number who acquire STDs. Lesser number who develop symptoms of STDs. Lesser number who perceive the symptoms of STDs. Lesser number who promptly seek medical care when symptomatic. So we getting lesser number reach the clinics, number seeking care who have ready access to care, lesser number perceived by clinician as possibly having STDs, lesser number perceived as possibly having STDs who can be tested for STDs, lesser number with objective evidence of STDs who get proper treatment, lesser number who comply with treatment, lesser number whose partners are treated and who are not reinfected. At each step of this, we get lesser number to who get full treatment, and we get, this is because of barriers, different barriers, either socially, stigma, and knowledge. وفي النهاية أقول الحمد لله رب العالمين و thank you for your good listening.